I now invite Dr. Jayant Venkatramani IYER. He's from across the Pork Strait from Sri Lanka, from a very good friend of mine. He used to be in SNEC. I think he still still part of the research team there.
I'll update everyone.
Right, okay. Now
it's under Dr. Jayant V. IYER. You're looking at Amit Pandey. That's not me, sadly.
Yeah, AV team, please. Okay, over to you, Jayant.
Oh, that's how I should go over.
Yes, please. So he's going to talk about differences between valved and non-valved tubes.
All right, please reset the timer. Thank you very much for that kind introduction, Vanitha. So I've now set up something called the Straits Eye Center in Singapore. We have a chain of clinics, and we hope to come to a place near you and work with colleagues like yourself, Vanitha. And I'm very privileged to be invited by her, and to a very august audience as well. So I'm going to be reiterating the wonderful talk I'm going to be following the footsteps of Professor Kirti. Let me just move this along, which is not working. How do I press enter, is it? This ain't moving. I'm doing both. Maybe hello?
It's not working, and
none of them are working.
When you start, please reset his timer. Thank you.
You press this, right?
Yeah, but he hasn't switched it on yet.
It's
No, it's fine. Oh, you can play with it. Yeah.
Oh, I see.
This one is a video, so you
Okay. Oh dear.
The slides smoothly.
Like that. Okay. Oh, okay. Let's. Okay, don't worry. I'll take over. It's fine. Let me just move to the next slide. Don't waste time. Alrighty. That's a guy pondering to be or not to be, to tube or not to tube, to further play on Vanitha's words. Actually, it's what Professor Kirti said is very interesting, because honestly, I've been doing less and less tubes with time. Interestingly, despite the increasing complexity of cases. Let me just use this instead. All right. No financial disclosures of relevance. I'm going to reiterate some of the points that Professor Kirti made with regards to glaucoma tube shunts. There's an overall history of glaucoma surgery, which really started off with this German physician von Graefe, with regards to peripheral iridectomy for angle closure, but really focusing on the history of tube shunts per se. It started off with the humble horsehair sort of seton that was placed in the anterior chamber that served like a wick to drain the fluid, but very soon people realized that didn't quite work. And it took about 60 more years for Molteno to finally realize that actually we might need to use more than just a wick to drain the fluid out to a subconjunctival, subtenon space in a capsule, and then slowly that percolates and drains out towards conjunctival veins, and that's how this device kind of found a resuscitation. And now we are doing more of the same. Krupin came up with a valved mechanism. Barwell, to South African, came up with his version of a valveless implant, and Ahmed, who is of Indian origin actually from IIT Delhi, moved on to California to create the Ahmed glaucoma valve device, which many of us do use. And of course, 2000s has been an explosion of many different minimally invasive glaucoma surgery. And honestly, beyond just that, glaucoma has moved towards earlier diagnosis, earlier pickup, earlier management, and better optimization. So honestly, with especially in Singapore, I'm seeing a lot earlier glaucoma, and just even removing the lens along with MIGS, with or without MIGS, is allowing me to, put away such invasive surgery. Oopsie daisy. What happens? There we go there. Alrighty. This works now. So I will not go through the indications because you've already beautifully covered the various indications. To summarize it, it's basically refractory glaucoma, secondary glaucoma after other incisional surgery where the conjunctiva is a bit screwed. Then you can consider doing tube surgery. But if the conjunctiva is too screwed, is too cicatricial, also tube surgery is a contraindication, because you're not going to get a good tube there. You're going to have a lot of problems. You might want to consider other procedures. So the tube killers really are basically better invasive, better medications, better trabeculectomy techniques with mitomycin C, and hawk-like control post-operatively, and diode laser with the micropulse. I'm using that a bit more frequently to reduce medication burden. Valve. So I was supposed to talk about valved implants and non-valve. So some of it is a repetition. I will gloss over the repetitive parts. Basically, the Ahmed tube is an archetypical valved implant that we use. It's a silicone tube which is inert, connected to a silicone sheet valve. The valve system works in a Venturi manner, where the inner outlet is diameter is smaller than the outlet. So there's a pressure differential governed by the Bernoulli equation, and it's designed to open at the opening pressure of 8 to 10 millimeter Hg. The truth is this, though. It's so design closer. The truth is, when they have done in vitro studies, they have found significant variability in this. So if it were to be this way, honestly, it'll be awesome. But the truth is, even in Ahmed glaucoma valved implants, we do see hypotony. Partly they say it's due to peritube leak. Partly it could be the valve mechanism. We have seen a couple of excellent videos on surgical technique for Ahmed, but basically, suffice to say, it's a bit more straightforward than valveless devices in terms of insertion, in terms of not really requiring you to find the muscles to place it snugly in the subtenon space in the supratemporal quadrant. Typically, you don't need ligating sutures, you don't need a ripcord suture generally, so it's relatively straightforward. The advantages are earlier intraocular pressure reduction. You don't really have as much diplopia or strabismus or hypotony events, especially in the early phase, as compared to barbells. When I was doing my fellowship in Johns Hopkins, we did an equal measure of both barbells and Ahmed. And honestly, the studies kind of prove themselves, where in barbells you have a lot more surprises, especially when the tube opens up. And in Ahmed, you get a little less of those surprises early on. But overall, the barbell seems to have better IOP reduction. So typically, there's higher medication burden. There's typically, quite often, they see in some studies 20%, in some studies up to 80% of a hypertensive phase, which is attributed to the pro-inflammatory cytokines that are present when the aqueous immediately passes through. So you remember, when you do a valved implant, immediately it starts working. So it immediately starts draining fluid, and you get a lowered pressure. But they say the pro-inflammatory cytokines induce very quick blood fibrosis, resulting in a hypertensive phase. So many of us very quickly start off the patient on hypertensive agents like Cosopt or Timolol to kind of reduce the aqueous, to kind of suppress the aqueous production. And that has allowed us to have better success rates, at least in Singapore. And actually some studies have shown that. The non-valve implants like the BGI come in 250 millimeter square or 350 millimeter square and plate result. Because what we do know is that the larger the plate, the better the pressure reduction in general. Some studies have shown that this may not be that clinically significant. So many of people are just sticking to 250 because it's easier. You don't need to sling it under the muscles. But most studies like AVB, ABC do compare the 350 versus the AGV. I will not talk about studies because we have a person who's going to give you a nice overview of all the summary of the studies. Surgical technique is slightly more complex, a bit more leche, as we call it in Singapore, a bit more cumbersome is the English word for it. But essentially, it involves similar. We try to place it in the supratemporal quadrant. There's always a need for ligating sutures because oddly, you would kind of want to ensure that you kind of keep it closed with a vicryl suture typically in the first 6 weeks. And we are really waiting for a capsule to form around the plate that you can see that I'm inserting there. All right, and the large capsule will then form a nice contained area for the fluid to then flow, typically at the 6th week mark onwards. This, I'm surprised, happens quite like clockwork when I use vicryl. I realize that the 42 days, 43 days, 44 days is when I start seeing a sudden lowering of pressure. And some people, previously I used to place this ripcord as a safety mechanism, which has an inferior outlet. The time is not fair. I have a bit more time. The inferior sort of conjunctiva for you to allow to remove the ripcord should there be some resistance. But in summary, that's kind of the main difference between the Ahmed and the barbells. Moving along. So this, I think no one showed you the barbells yet, so I'm just going to show you that. There are many techniques to insertion. One technique is to tunnel it. Another technique is to just put it about, like he says, 2 to 3 millimeters behind the limbus, enter it, and then in the US, I had access to split thickness, half moon corneal graft, which was beautiful, and it kind of covered it well. In Singapore, because we do so many traps, I'm just used to doing a long flap to cover the tube. And actually nowadays I do the technique which is very similar to the one that Aravind doctors are talking about, which is the tunneling technique, to not even have any flap or any of those things. And that seems to work pretty well, at least in the last 3 to 5 years. As we have already discussed, it has better long-term IOP reduction, reduced medication burden, but it comes at the cost of earlier part of the treatment, the IOP is not well reduced because you are ligating the suture. So it doesn't work in the initial phase. So you might need to use a lot of glaucoma drops. And there might be a sudden drop in pressure at the 5th, 6th week mark, which you have to be careful of. So you have to watch them very closely post-operatively. There's another Paul glaucoma implant which was actually developed by my colleagues in Singapore in the National University Hospital System. They tried to kind of combine the advantages of both. They wanted to have a larger plate so that there's more drainage, but they also wanted to have a smaller tube without a valve such that there's reduced chance of hypotony. Is there truly reduced chance of hypotony? Studies have shown that they still get hypotony, unfortunately. They do have those complications, but what they have found in their not so long-term data over the last 2 to 3 years is they tend to get a bit better results than are met. So in NUH, they exclusively use a Paul's glaucoma implant. In the Paul's glaucoma implant, they do not, because of the lumen size of the bar valves and AGV is about 0.3 mm internal diameter. The lumen size for the, the Paul is about 0.12 millimeters. I'll be done soon, don't worry. So just very quickly, typical case studies to illustrate the point of when we use what. An example would be a neovascular, single-eye neovascular patient, glaucoma patient with significant peripheral anterior synechiae, which would really not do well in a trab. In this case, he was refractory after having undergone the bilateral TPPV vitrectomy and endolaser. His eyes were cooked. Pressure was 30-40. He needed quick drop in eye pressure and better management. So we anti-VEGF'd him, and we also put a tube in his eye. Within 8 months, it did not succeed because this patient is also non-compliant to medications. And I actually managed to do a limited transscleral cyclophotocoagulation. And over the last 2 to 3 years, he has stabilized very well. But this is a tough patient because there are a lot of other factors. A typical case that might require a BGI as opposed to a valved implant would be, for example, a 70-plus-year-old primary open-angle glaucoma patient. I'll be done. For whom there's a failed bleb. And he did very well. Like the sixth week, AC went flat, hypotony. We had to stent the tube. So we had this technique we have described in the literature where we use a supramid or sometimes a nylon Prolene suture where we go in across intracamerally to plug the lumen, and that worked beautifully for this patient. In summary, valved and non-valved GDDs have a reasonable success rate. You have to watch out for each one's complications and each one's different techniques. And ultimately, it's surgeon preference, surgeon comfort, what's available to you, what works best for the patient, because we have a plethora of options to choose from. Thank you very much.